So we actually see myopia happening or axial length growth happening more rapidly in an eye that doesn't see well. And that's just sort of clinical.
Welcome to EyeCan, a podcast about ophthalmology through a uniquely Canadian lens with Dr. Mona Dagher and myself, Dr. Hadi Sahed.
Bienvenue à EyeCan, un balado sur l'ophtalmologie sous un angle typiquement canadien avec le Dr. Hadi Sahed et moi-même, Dr. Mona Dagher.
Season 4 of the EyeCan podcast is brought to you by Bayer Ophthalmology. We thank them for their support. Nous aimerions remercier Bayer Ophthalmology pour leur support de la 4e saison du balado EyeCan.
We will share our experiences as ophthalmologists today and tackle some of the challenges we face as healthcare providers. Hey there, eye care enthusiasts. It's Mona and
Hadi, back at it again with EyeCan.
You know it, Hadi. Today's episode is going to be a real eye-opener. Pun intended.
Mona, always with the puns. I promise, folks, today's discussion will be just as sharp as Mona's great wit.
Hey, we're here to keep it both informative and entertaining, right?
Absolutely. So whether you're a seasoned ophthalmologist or just as fascinated by eyes as we are, you're in for a treat.
On this episode of EyeCan, we introduce our listeners to the topic of myopia with returning guest, Dr. Vivian Hill. Dr. Hill completed a fellowship in ocular pathology at the University of Ottawa, then completed an ophthalmology residency and a pediatric ophthalmology fellowship in Calgary. Dr. Hill is currently an assistant professor at the University of Calgary, and her clinical practice focuses on pediatric ophthalmology and adult strabismus. She led undergraduate ophthalmology for over a decade and led a revision of the medical school ophthalmology curriculum at the Cumming School of Medicine. She is a member of the examination board of the Royal College of Physicians and Surgeons of Canada as an optics and pediatric ophthalmology examiner.
Dr. Hill sits on the executive of the Eye Physicians and Surgeons of Alberta as past Peace Chair and current advocacy lead. She is also the COS Advocacy Council Chair. Her term is ending in June 2024. Her interests include pediatric ophthalmology and strabismus, retinopathy of prematurity, medical education, and vision safety in the setting of injectable medical aesthetics. She is a former director of the board of West Island College in Calgary, which excels in academic rigor and experiential learning. She has received Calgary's Top 40 Under 40 Award, as well as teaching awards at the Cumming School of Medicine. Vivian, welcome back to EyeCan.
It's a pleasure to be here. Thank you for having me again.
Vivian, pediatric ophthalmology is such a needed subspecialty and also so unique compared to the adult subspecialties of ophthalmology. So I'd love to hear more about what inspired you to specialize in pediatric ophthalmology and particularly focus on myopia.
I always enjoyed working with children, and I also enjoyed the angles of strabismus. I know most people don't, but I really enjoyed strabismus throughout residency training. I spent a little bit of extra time working with Dr. Zakon in Ottawa in neuro-ophthalmology, and then working with Shrifel Defrari as well in adult strabismus clinics. So I really enjoyed a combination of strabismus and pediatrics. And pediatric ophthalmology, to be honest, was also something that was needed. So I liked a lot of the subspecialties and danced with a few of them before choosing. But, some of it is what we like, and some of it is how we can be of service to the community. So for me, it was a bit of a combination of both. And to answer your second question about why myopia, well, that started with a visit to a basic science lab at the University of Calgary. And it was the lab of Dr. Bill or William Stell. And he, prior to his retirement just a couple years ago, he had a lab researching the basic science of myopia. And he and his students studied animal models of myopia, mainly in chicks, and it was form deprivation myopia, which covered a lot of structural, functional, and pharmacologic properties of the retina that both played roles in the causation and prevention of myopia. And then you sort of say, well, why were you there? And I was there to teach some of his PhD and master's students how to refract the chicks. So I came in sort of to teach them how to refract, and then through that got to know Dr. Stell a little bit more. And he's quite amazing. He is a world expert in myopia research, and we had him in our backyard in Calgary. And then, even after he retired, and so that now we're 2024, so probably it was 4 years ago in 2020, he's actually continued on as a scientific advisor to several prominent myopia research groups in Asia. So he kind of got me involved and had me, I went to it or attended, this was actually virtual, a myopia conference, and that sort of got me a little bit more interested. But then also, when I had questions, I could email him and he would help me along the way clinically. And that made me think that we could perhaps intervene a little bit more in that bridge between basic science and clinical medicine. So I was an early adopter of some of the strategies to prevent myopic progression here in Calgary. I think probably the first, or one of the first, certainly in Alberta, which may or may not. I mean, not everything we do, we do things with the best research at the time, and some of those treatments, maybe more recently in recent literature, are not harmful, but may not have had as much impact. Although modifying them, we're always doing that in medicine, trying to get a little bit better and better. So I also got a chance to chat with him briefly before this podcast about some of the basic science as well. In myopia research that is really expanding.
That's so interesting, Vivian. And I'd love to hear a little bit about refracting chicks and how does that go compared to refracting kids?
It's the same. I mean, this was a while back, Hattie. So I'm a little bit long in the tooth here now. But really, you just do it the same way with lenses. And he had a retinoscope, and you're doing the with and against reflex. So
wow.
I mean, I'm not sure if they might do things a little bit differently now. I mean, certainly elongation of the axial length of eyes is really important in myopia research, and I suspect things have evolved a little bit. I haven't been back to the lab. They all know how to refract now, so I haven't been needed.
It's incredible, though, and probably the amount of collaboration between kids and chicks may be almost equivalent.
Yeah, there's all sorts. There are all sorts of myopia models in both primate and non-primate animal models, and I mean, I guess a lot of the studying or a lot of the research is about having a model that induces myopia through various mechanisms. So how do we make the eye grow faster? How do we create an environment that creates myopia? And then what intervention might slow that induced myopia? So those are kind of the balancing things in a nutshell, like without getting into it's more complicated, I'm sure.
Mm-hmm.
But in a nutshell, they're able to find models that create myopia, and then how do you prevent it from happening?
Vivian, another question I had about your experience as a pediatric ophthalmologist was I was wondering if, as you went through, training and then practice, if your experience as a parent impacted your practice or your approach to pediatric ophthalmology in any way?
I think so. Certainly at that, and I think I worked a lot as a camp counselor in Ontario in summer camps. So I spent a lot of time looking after kids in that age group, and I've always been sort of happy to manage them, and I don't have a lot of patience for children. And I think having my own kids, you empathize. It's quite interesting because when they're really little, and your patients are little, and they're kind of the same age as your kids, you can really empathize with the parents. And then, my children are now 19 and 21 and in university. So it's a bit different, but you certainly, I think you remember it personalizes the experience a little bit more, and the impact that some of our treatments might have on day-to-day life, and also visits, right? Like it's not that easy to bundle up. Right now we're minus 30 in Calgary, without wind chill, with this Alberta deep freeze. So, I mean, it makes you think, okay, well, you can't just pull patients in for quick checks like that. That's a big impact to a family, right? You have to, then do you bring all the kids? Does a parent have to take time off work? So I'm pretty cognizant of that. And I try to give a little bit of warning sometimes to patients about how often they'll need to be seen, how much time that's going to take, and show just some empathy, and also, I'm a little more reasonable about switching things around, and perhaps doing appointments for younger children earlier in the day when possible. I mean, we don't always get that done, but I had a better appreciation for nap schedules, and how tired children are not sleepy. They are not as easy to examine. So I used to, that was one thing I think before becoming a parent, I used to think, how people say, oh, they must be tired. That's why they're, maybe active or crying or being almost more hyperactive. And until I had my own children, I didn't realize that, yeah, it's not like, oh, I'm tired, let's go for a nap. Like there are actual behavioral changes or a difference in the ability to concentrate when kids are tired. So you really have to work around things like nap schedules and time of the day to optimize the data you can collect during an exam, and to not create a maladaptive response to the medical exam. So it doesn't take much in young children to create a fear or maladaptive response. Like if children are in an environment and they have a bad experience, then the next time they're going to be like, I'm not so sure about this. So those sorts of things you become a lot more aware of, I think, as a parent, because you're living them.
You're very empathetic. That's really wonderful. It does take a lot of patience and a lot of empathy. It's really incredible. So that's really inspiring.
Oh, good.
And what inspired you to take up the advocacy role? And how does your role as COS Council on Advocacy influence your practice and your patient care and your approach?
I think for advocacy, that came a little bit, not much to do with pediatric ophthalmology, more to do with some changes in the way care was proposed to be delivered in Alberta, with expansion by non-surgical eye care providers, optometry, into potential surgical leads. And it's not to get into a debate about that, but more about the fact that the surgeons or the professionals that were doing 100% of the surgery on eyes in Alberta were not consulted. And I'm not sure that, was necessarily an intentional thing, but it showed me that you need to have an active advocacy arm in order for people who make the decisions on policies that can affect patient care to have them know you, to have them be aware of what you do. Because we practice, we're so busy in our practices, but and you and I know what each other do, and physicians will know, but if you're outside of the field of medicine, you may not understand the difference between what different members of the eye care team provide. And so that rapid sort of push for scope expansion without discussions or having input coming from the surgeons really struck me. And I worked on a campaign or on some education material for government and policymakers. And then through that, I became involved a little bit with advocacy and applied for the COS advocacy role. But in terms of what does advocacy do for pediatric ophthalmology specifically, what's been great about this advocacy role is that I've had the opportunity to speak with media, to highlight some of the work that the COS does and that its members do, including sort of some rural outreach, including the social media with See the Possibilities. And those outreach programs that are part of the advocacy framework done with the COS do reach patients, and it is neat to talk to patients about what they've heard either on the news, if I've had the opportunity to speak on media, or what they come back with after either looking at the COS website or looking at some of the social media posts that are educational for ophthalmology. So it does create a nice jumping board, I guess, for some discussions about broader vision health. The other thing that I think is great with the advocacy that potentially might have some impact in pediatric ophthalmology is that we, as you know, have been advocating for a national vision health strategy, and that for Canadians. So a strategy that would encompass eye care and perhaps a research hub and communication and education for Canadians that would be constant between provinces. And we were pretty excited to know that a bill was recently unanimously supported in the House of Commons and passed its first reading in Senate. So these things take a long time, but that is a great step towards advocacy for patient care and education, and perhaps even things like similar vision screening programs or strategies towards in pertaining to this podcast in myopia prevention, or at least slowing the progression.
Yeah, we're very excited about that too. It's going to help a lot in advocacy for ophthalmology and eye care in general.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we will try to incorporate them into future episodes.
I'm Phil Hooper, and I listen to the EyeCan podcast.
So considering your extensive experience in pediatric ophthalmology, and we've heard a lot in the media recently in the past couple of years about myopia, can you discuss more the significant recent advances in the treatment of myopia and how it has impacted your practice?
Sure. A lot of the recent advances, I think, are spurred on by the fact that myopia is increasing worldwide and is becoming an increasing health burden. And right now, it's expected, well, in 2020, I think the numbers were about 1.4 billion with myopia, and certainly depending on the definition, perhaps those numbers can change, but the projection is to be close to 5 billion in 2050. So that's going to create a lot of issues, not just with vision health and loss of vision, potentially with secondary complications of myopia, particularly retinal complications such as retinal detachment or myopic macular degeneration, but also just even in globally in loss of productivity through uncorrected myopia as well. And I also recognize, so this is part of this drive for all this research. And you can say, why do we think the prevalence is increasing? And we do know that increasing levels of education and near work, reduced time outside, urbanization, as well as most likely increasing screen time, does increase myopic progression. It does perhaps bring the onset a little bit sooner, and therefore the prevalence of myopia as well. And, the earlier that myopia starts, the more worrisome it is, because children with early onset myopia are at particularly high risk for complications later on. So that's sort of this global issue that is, we're seeing these increasing amounts of myopia just going up and up and up and up. And then, fast forward that, we want to avoid increasing burden because really it's not just a pair of glasses. I mean, it is in some cases, but in many cases, it's not just a pair of glasses. And I really recognize and empathize with the anxiety that parents have when their children's myopia prescriptions kind of go up, because we're all kind of fast forwarding and extrapolating, if their glasses are getting worse, what's that going to mean in 5 years and 10 years and down the road? So I think as a pediatric ophthalmologist, there's a lot of concern, and because it's so common, even though it is more of a refractive issue, and we're not treating an acute, like it's not an acute point intervention with a surgery or with medications or something. It's a big deal, and it is concerning for families, and also for me. And I think that has had me look into ways to mitigate rapid progression.
How do you address the various risk factors for myopia in children, and what are the preventative measures that you recommend to the parents or the children?
Well, the biggest risk factors are an interplay between genetics and between environment. We know that genetics matter for a few reasons. We know that parents, if there's one parent and two, that increases the risk. We know that twin studies, identical twins, are more likely to like if one has myopia, the other one's more likely than a fraternal twin, and you could assume that their environments are similar. And then there was also a recent I'm not sure when it was, called the CREAM study that showed about 24 genetic variations in genes associated with myopia that can increase the risk of getting myopia by like a factor of 9. So we know there's genetic factors. So we don't do genetic screening. That was more of a research thing. But family history we do ask for. So we know that children with family history are at increased risk. So right there, if I see parents with glasses or I ask them, I will discuss that their child might be at increased risk and what they can do non-medically to mitigate that risk. And that's all lifestyle. So that is time outside. It's reduced near work and increased time outside. And that's been quite well studied. And it's felt to be about light intensity. So time outside is time during the day outside in the sun is exposing the eyes to increased wavelength, high intensity, a rich visual environment with movement, with varying wavelengths, and all these things in animal models like light intensity have been shown to slow myopic progression. And we sort of say, well, why does that happen? Well, we think that light intensity increases retinal dopamine, nitric oxide, and retinoic acid. And those compounds given to animal models actually reduce myopic progression. So it's felt that there's some biochemistry involved. And then also what's really interesting that I've learned more recently is that choroidal blood flow is increased with higher intensity, like outdoor light. And if you have a reduction in choroidal blood flow, there's a relative hypoxia, and that can actually set up these metabolic pathways that affect scleral extracellular matrix, making it more distensible at normal intraocular pressures. So the model for myopia, this rapid eye growth in kids, it's not like, oh, it's stimulating growth. It's more that something is happening in the biochemistry, mediated probably by retinal cells and choroidal vascular supply, that create let's say a more malleable or looser extracellular matrix of the sclera that make it vulnerable to growing at normal intraocular pressures. So that's sort of what's felt to be the basic science. And we can kind of think to pediatric or infantile glaucoma with buphthalmus and a softer sclera with high pressures, and that eyeball grows. But in the myopia model, it's normal intraocular pressures causing expansion of a sclera that has perhaps been, and I'm not an expert in the detail of the basic science, but the sclera that it has had some changes in its extracellular matrix due to biochemical reactions, probably coming from the retina and choroid, that make it more distensible. So that's a little bit, that's the basic science, but basically it's spend some time outside, and that light intensity and perhaps the constriction of the pupil, creating some sharpening of images might also help, because we do know that kids who have a blurred retinal image, so whether that's from a cataract or from corneal scarring or from something that occludes their visual axis, we know that eye grows faster. So we actually see myopia happening, or axial length growth happening more rapidly in an eye that doesn't see well, and that's just sort of clinical, but also those models check out in animal research as well.
Vivian, it's so great when research findings kind of make sense, and a lot of what you're saying makes sense. And I'm trying to put myself in your clinic lane as a parent with a kid with maybe a little bit more myopia than expected, and you giving me these research findings. Spend time outdoors, more light, more brightness, more physical activity. And, we're here in the middle of winter, thinking of, it's cold outside, it's not so bright. So all this to say, all jokes aside, how are you giving concrete recommendations? Do you have like a to-do list on how to help parents actually do this? Because, it must be so hard to make sure you're doing, the most impactful things to help reduce myopia.
Sure. And I didn't get into this, but the other thing is education, right? So we know that increasing levels of education, so more rigorous academic programs, more homework, particularly in children in that really vulnerable age, and maybe 5 to 10 years of age, more homework is associated with more myopia. But how do we say don't do homework, or how do you balance education and doing well in school, which is absolutely important in so many families' lives? Like, it's a real priority. And I sometimes wonder if some of the models of too much homework after school, does it actually benefit the child? So in terms of concrete things, what we say is, I realize you'll have to be on screen at school. I realize that there are demands for homework, but perhaps we can reduce non-necessary screen time. And during screen time, can you take some breaks? Now that actually has not been studied, perhaps, but we talk about every 20 minutes, looking kind of far away, and giving that sort of accommodative strain a little bit of a break, and perhaps reading with good light intensity, reading by a window, taking the opportunity to go outside during recess and at lunch break. Can you walk to school? Can you spend a bit more time outside on weekends? And, we balance that with sun exposure. So I perhaps don't recommend dark sunglasses in children with myopia. Now, that doesn't mean you need UV exposure, right? You can still wear sunscreen and a hat. And, some glasses that are not as dark will block UV, like even regular glasses block UV. So we're not looking for UV exposure. We're looking for light intensity over kind of a broad or natural sort of chromatic range in terms of wavelengths. And a lot of families just need me to tell them. Like a lot of the parents already don't want the child to be on screen or on a small tablet holding it very close. And sometimes I just have to talk to the child directly and tell them that they have to take on a bit of the responsibility and make a choice. I had one child today say that he put like some kind of timer on his top 5 apps that tell him when he's exceeded the time. He said, Dr. Hill, I just don't go on it once my app tells me that I should probably not be back on it. And I was like, well, like they're pretty resourceful, the kids, so they need to buy into it. That's the main thing. So the parents need to buy into it, and the children need to buy into it. And I also encourage that or emphasize the fact that it's really good just overall for their health as well. And you can't sweat it during the winter. Like at -30, you can't go outside, but you can sit near a window. You cannot read in the dark, and you can move screen further away from you. So it's not as close. And you'll ask me about, does reading and what our grandmothers told us about don't hold the book too close, it'll ruin your eyes. Does that really pan out as a risk factor to myopia? And, the answer is it does to some extent. But bifocals probably don't work that well. They work a little bit, but that's not the whole thing. It's not just about accommodative fatigue, right? If you're accommodating to a near object and your ciliary muscle gets fatigued, then you're not bending light as much, and then the light is going to focus behind the retina, creating a relative hyperopic blur. And so the feeling is that if you have a hyperopic blur, the eyeball will grow just because that's what it does when there's a blurry image, it grows. And so it was thought that just near work alone, perhaps a bifocal glasses could reduce myopic progression. And there was a big study called the COMET study that studied progressive bifocal ads, and they did find there was a difference between wearing a progressive bifocal ad and not, but it wasn't really enough oomph. Like it was statistically significant, but not clinically impactful. But a lot of times reading dim light, you combine that with reading it near dim light, not going outside, those things add up together and create an increased risk for myopic progression. And if you combine that with parents that both have myopia, then we can predict probably that child will become myopic and possibly also more myopic than their parents.
Screen time is such a hot topic, beyond the eye, and this is just one other reason to try to manage screen exposure for our kids. But I as a parent, I know how tough that is. And as I'm listening to, some of the recommendations you made, spend time outdoors, physical activity, bright light, movement, I'm thinking our long winters, like skiing for those who can, seems like a great solution that just checks off a lot of those items. Now, of course, skiing is not accessible to everybody, but for those who enjoy it and who can do it, I think it checks off a lot of boxes. So I'm going to keep that in mind.
Sure.
Another comment I had, and my general impression is that myopia is not really feared by the general public as much as it should or could be. And frankly, even for myself, until I was in ophthalmology residency, I didn't really have an awareness that myopia had any consequences beyond imposing the need for glasses or contact lenses. It was just a refractive error in my mind. But of course, we do know that myopia increases the risk of like many ocular diseases, some of which can be visually threatening and blinding. So now with the World Health Organization predicting the increasing myopia prevalence, what public health strategies do you feel we should be prioritizing to address this issue that's growing?
Right. I think that from a public health strategy perspective, it's what I talked about in environment. I think it's education for the public, for parents. It's encouraging a healthy lifestyle. It's balancing education with physical activity and with the option of spending time outside. It's also about supporting research and clinical trials in the medical management of myopia as well. It's about educating patients who already have myopia about the signs and symptoms, and perhaps the fact that they should see an ophthalmologist or potentially an optometrist to have their vision checked if they do have high myopia. So they need to be taught about the signs and symptoms of retinal tear or detachment or changes in sort of a macular grid potentially, and perhaps that's a little bit more specific. So, in terms of general strategies, I think it's really about for me my feeling is it's about lifestyle. It's about balancing the homework and the studying, and do we need to do 3 or 4 hours of homework? Like, does it translate into better education? So and can we incorporate time outside in the schools and ensure that we protect those gym hours? And can we build, have schools with better light sources as well? So all those things could be and although there will be other researchers and basic scientists that could weigh into the details of that. But to me, it's a lifestyle strategy primarily. I think that's what delays the onset. That's what can mitigate some of the risk that we have from increasing levels of education. Time outside almost is a bit of an antidote to the stimulus of increased reading and near work and homework. And then I think, for patients to be aware that there are some treatments that do slow progression in addition to lifestyle, and those have been extensively studied. Not perfect. We don't know exactly when, how much, and who specifically to treat, but we do know that two main interventions work. I always say it's light, lenses, and atropine. So light is your time outside, and we talked about that already. Lenses are not bifocals, but peripheral defocus lenses. So these are lenses that are that bend peripheral light into the eye. So it focuses the light on the macula. So that's great. So the patients see well and it's clear, and we know we want to give the appropriate refraction for myopia. Like under correcting it probably doesn't slow progression, but we don't need. We can bend the light in the peripheral retina, and that peripheral retina might actually be a bigger stimulus to eyeball growth than just the macula. I mean, there's lots of cells, lots of rods, and those seem to work by those variety of there's contact lenses that do that you wear during the day, and then there's orthokeratology, which I'm not the biggest fan of, but that probably does something similar. And orthokeratology is when you wear contact lenses at night to sort of flatten the central cornea, and then you take them off during the day, and you're not myopic. And part of the reason they work is they sort of, I'm going to use a non-medical word, like smoosh the epithelium centrally more than peripherally and remold the cornea a little bit, but also create a bit of this peripheral defocus where the light is bent in peripherally, so it doesn't give a stimulus for growth. And that can exist in eyeglasses as well. So there's contact lens versions and eyeglasses versions, and those are a little bit more expensive, but I do offer those to children. So just even education that there are myopia, not preventing, but myopia slowing lenses available. And then also that there are eye drops that do slow the that have been shown to slow the growth, although some of the long-term data, when they were just used for a few years, like 2 or 3 years, the long-term data, 10 and 20-year follow-ups out, and perhaps using atropine just for a couple of years, it doesn't slow the final out. It doesn't help after 20 years. So there's some work that needs to be done on optimal timing of the treatments and optimal dosing. But perhaps just to say that it's for treatment, it's a combination of these lenses and atropine. And the optimal dosing is probably in a lower dose range, but not the ultra low dose of 0.01%. So what's interesting with atropine is there's 100-fold difference in the treatment. So the first study did 1% and then placeboed at 0. And then further studies treated with 0.01% and 0.1 and greater. So it's quite interesting to me that you have 100-fold difference in the dosing of atropine, right? And to try and fall into the correct dose. And clinical trials are time consuming. They take a long time. They're expensive, but they have to be done because they can really show us things that we didn't think before. So
it's usually once a day, once a week. How often do?
So typically the treatment's QHS because it's not related. It's related to atropine's biochemical properties. Like it's a muscarinic antagonist, maybe an alpha agonist. Like these are presumed roles. So there's some people studying alpha-GAN now for brimonidine for myopia prevention. So it can be done at night, which is nice. You can I usually recommend either 0.05% QHS nightly. And I tell parents, you're probably going to be on it for years and years. And I follow patients with a combination of axial lengths and cycloplegic refraction. So some of the issues with studies and are, these drops have to be compounded in pharmacies. Are they compounded evenly in all the study sites? Are they, how long does atropine stay active for? When does it break down into its components?
Can you wait for stability?
I don't know how long is it stable for, and depending on how it's mixed. Like these are some of the issues that are being studied. It does break down. So atropine does break down into components. So I think I prescribe a new bottle every month, and I prescribe the medium to high low dose. So either anywhere between 0.025 and 0.05. So I tell parents it's 5 drops of medicine in a total of 100 drops of saline, or sometimes I use the term water. So they kind of get an idea of the dosing, because the higher doses of atropine that were originally studied in the original ATOM 1 trial, it was 1%. And, 1% is a cycloplegic big eye and it's going to last. And so, the kids are blurry, they are light sensitive, and that's just not practical. That's not going to work. And that's quite a big dose. So the lower dose ones, I think, are a lot better. But and in Asia, the ATOM 2 trial, so that would have been in I think it was like early teens. That one studied the 3 variable doses. So they looked at ranging between 0.01 and I think 0.5. And they actually found that the low dose was the best because there wasn't a rebound effect. And then other North American studies, after studying the 0.01% in North America, didn't show as much of an effect. So the Pediatric Eye Disease Investigators Group, they did a study and they didn't show an appreciable difference between placebo and 0.01. But 0.05 seems to make a difference. And so the big issue is then washout. When you stop, like in some of the studies with higher doses of atropine, when they stopped the atropine, the progression was more rapid than in the placebo group. So it kind of got rid of the benefit, or not all of the benefits, but it got rid of some of the benefits. So really it's trying to find this optimal dose that slows. And for now, I'm thinking it's 0.05. And then as you're kind of thinking that the eye growth is slowing down, I don't cold turkey stop it. I taper it.
What's
So I
the
might
length of
switch
the
it to a
duration?
0.02. It can be years,
Wow.
3, 4 years. So it's a huge investment, right? These drops are not inexpensive, although they're coming down in price, but might be like $60, $70 a month. Like that's a lot of money. And having to take the drops every night. And you say, well, what's the effect? It's about 50% reduction in progression. That sort of seems to be for most of these things. There start trials combining lenses and atropine. So we'll see if it's more, but it doesn't stop it. It doesn't reverse it. It just slows it. And so is that worth it? And you can debate both sides.
And recently we've been hearing about personalized medicine. Can you tell us how important is personalized medicine in management of myopia in children?
I think it will be important. I don't know that much about it, but we do know that some children are responding more than other children. And I think that will become a field. So I mean, that's part of it. Like if you look at perhaps variations in ethnicity, but between countries and studies, like maybe they're, I don't know, the genes, we don't do genetic studies yet on every child, but perhaps in the future that might come to play. I suspect it will. And then you'll know which children will respond better. But right now, I can't answer that too intelligently.
It's a growing field.
It's a growing field. Like I don't have that so much in my practice. My personalization is I look at children that seem to be progressing rapidly that are at high risk, and those are the ones I offer the intervention with the balance that they're not the interventions aren't the be all and end all, and you really have to watch where you put your resources as well, right? And you have to make that decision with the parents, and you can't, I don't need maybe guilt you can't sort of say, well, you have to do this, or because we don't really know that. We know that it slows progression. We know as well that but we don't know for sure in 20 years is that going to have a significant impact on their eye health. So we think it does a little bit. We know that the drops are safe. That was one good thing about the 20-year data and 10-year data, is that the drops are quite safe. There wasn't really any adverse side effects. But I think that there has to be a real balance, just like there's a balance with how much schooling you need to do to be educated and be able to thrive and contribute in society versus, being healthy and have an outdoor lifestyle. Like it's all balanced. Then how do we treat effectively as possible without pulling resources from other things that are important as well? So I think that's a discussion here. It's always a bit of a gray zone, and you can trend one way or the other, and it is individualized. And I think the more data we can get going forward, probably we might not have to guess anymore. It might just be that, oh, you have these gene variants, you're going to use myopia, or you're going to use atropine to treat. So for this long, that would be great.
All right. As you know, and you've been a prior guest on the EyeCan podcast, we always love to ask our guests how they spend their time outside of the office. Can you tell us what books you're reading, any podcasts that you'd like to share, or any activities you're doing?
Yeah, I just read a book over the holidays by Tara Westover called Educated, and that was a really good, a really amazing story about a girl who was raised in a fairly orthodox or almost abusive Mormon family, and it was this interplay between a strict sort of predetermined faith and the steps it took this young girl to actually educate herself and then start to see herself as part of the world and not just sort of predetermined by her predetermined that she couldn't be educated and had to stay home and be because she was a girl. And it's a really interesting memoir, and it's true. So it's her memoir. And I thought that was an amazing story about her religion, her love of her family, her guilt of leaving. And she ended up going to Cambridge and getting a doctorate in history. And she really said, how do we even know history? Who writes history? And it was a great book. So that is the one that I've read. And I interestingly, and I know this is a bit off topic, a girlfriend gave it to me. And I was like, oh, this is a great book. And I show it to my daughter who's 21. And she's like, oh, Mom, I have it upstairs. I've already read it. And I'm like, oh, okay. And then like time outside, I'm doing time outside. So I cycle. So I love biking. I'm trying to get better at it. I'm not that good, but I do road and gravel. And then in the winter, although not at -30, I've been taking up fat biking or fat tire biking, which is with studs and a thick tire, and you can kind of go on trails. So it's quite fun. I'm trying to be a better skier. I am not a terrible cross-country skier. I'm learning skate skiing a lot more. I'm not a great downhill skier, even though I'm living in Alberta, but I still go. So I'm trying to do things like that. And, I like cycling trips, and trying to plan a trip with the kids now gets harder and harder with jobs and school. But my daughter is graduating this year and she wants to go to Patagonia. So
nice.
Who knows?
So you practice what you preach.
I'm trying to as best I can.
If you were a kid, Vivian, your risk of myopia would be quite low. So that's great. And you are way cooler than I am. I love hearing about everything you're up to. Thank you. Sounds like a lot of fun. Well, what you shared today was so useful. And I think with the increasing prevalence of myopia, it's so useful for our listeners and everybody there. They know to realize how important the myopia epidemic is, and how there are things that can be done to help reduce the burden of this. So thanks for sharing everything you know about this, and clearly your passion as well. So that was really a great chat. So thanks again.
Thank you.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we will try to incorporate them into future episodes. Season 4 of the EyeCan podcast is brought to you by Bayer Ophthalmology. We thank them for their support.
Nous aimerions remercier Bayer Ophthalmology pour leur support de la 4e saison du balado EyeCan. Thank you from the Canadian Ophthalmological Society.
EyeCan is written and directed by Kim Teitler and produced by John Allaire from Allaire Strategic Works.
EyeCan is available on Apple, Spotify, and Google platforms, and of course, through the COS Practice Resource Center.
Some episodes this season will include relevant links and show notes, so be sure to check episode descriptions to learn more.
Thank you for joining us this week. We look forward to bringing you more episodes.